Welcome to AETCM, the emergency medicine channel. Today let us discuss about basics of arterial blood gas analysis. We take ABG for various conditions like patient have breathlessness due to cardiac disease, lung disease, acidosis, and we also take ABG for getting electrolyte values because most of these newer ABG machines have electrolyte values. They have creatinine, they have lactate, all these things. For that also we take ABG. So normally before doing an ABG we have to do a modified Allen's test to know the patency of ulnar and radial artery. If both arteries are patent, we should take ABG from that hand. And ABG will give reports like pH, PaCO2, PO2 like that. Now first value is pH. It measures the hydrogen ion in blood. pH inversely related to hydrogen ion concentration. Hydrogen ion increases, pH decreases. Hydrogen ion decreases, pH increases. So hydrogen ion determines the acidosis or alkalosis in blood. pH is maintained in between 7.35 to 7.45 in our blood. This is maintained by our lungs and kidney. So lungs will try to increase or decrease carbonic acid. Kidney will try to increase or decrease hydrogen ion and bicarbonate. We will see the buffering system afterwards. And we get ABG like this. pH will be in between 7.35 to 7.45. Anything above 7.45 is alkalosis. Anything below 7.35 will be acidosis. So right side you can see the sample ABG. Lot of values are there. Some ABG machines give even values of electrolytes, sodium, potassium, calcium, phosphorus, magnesium, then creatinine, lactate, base excess, so many other values also there. Now this buffering system in our body that pH maintains between 7.35 and 7.45 is maintained by our lungs and kidneys. You can see the equation here. Carbon dioxide plus water gives carbonic acid. Same times kidney side hydrogen ion plus bicarbonate gives carbonic acid. So this equilibrium is maintained by our lungs and kidneys in our body. If there is a problem in the metabolic side, lungs will compensate for that. If there is a problem in the side of lung, then the kidney will compensate for that. That is called as compensation. You can see here there is a formula called as Henderson-Hasselbalch's equation. That from that formula you can calculate the pH, that is 6.1 plus log bicarbonate by PaCO2 into 0.0301, and that pH will be in between 7.35 and 7.45, and it is maintained by lungs and kidneys by carbonic acid and bicarbonate plus hydrogen ion. So now need to learn by heart this Henderson-Hasselbalch's formula for practicing. For an MBBS student they have to learn it. Practicing this will be automatically given by the value in the ABG paper. So in the lungs, water with carbon dioxide levels either increase in breathing or decrease in breathing, you can maintain the carbon dioxide level. Carbonic acid is formed or removed. In the kidney, hydrogen ion is removed or retained. Bicarbonate either removed or retained by the kidney, and that also produces increase or decreased alkali levels, and it maintains the pH. This part of the like buffering system in the lungs is controlled by respiratory center in the medulla. So whenever there is acidosis, we can see most of the patients are breathing fast, and they try to remove carbon dioxide. When you are breathing fast, you can see the oxygen levels increases and carbon dioxide washout occurs. So acidosis, you can see all types of acidosis. Patient is breathing very fast and carbon dioxide is removed from the body. This is controlled by our respiratory center in the medulla. Now when we take ABG, sometimes I have already told that we take sampling for other parameters, like you can take a sample for electrolytes, you can take a sample for creatinine, you can take a sample for lactate. So all these things no need to prick an artery. You can just take a sample from the vein and send. But whenever we are taking venous sample, we have to always document that it is from the vein or it is from the artery. But however, when we are taking arterial sample or a venous sample, there is only a mild difference between many parameters other than carbon dioxide and oxygen. pH difference is only 0.03 or 0.04. That is only difference. So clinical practice, venous sample or arterial sample will not have any difference in ABG or VBG. Like patient who is having metabolic acidosis, like diabetic ketoacidosis, you just want to know whether the acidosis is corrected or not. Initial sampling can be ABG, or later you can do only VBG, no need to prick the artery. If there is an arterial line, then that is good, but otherwise you can only take the sample from venous side and do the testing. So pH, there is no much difference, but PCO2 and PaO2 has got lot of difference between arterial and venous sampling. PaCO2 on the arterial side 35 to 45, whereas venous side 40 to 50, slightly higher. PCO2 is 75 to 100 in arterial, very low in venous, because oxygen is utilized in peripheral tissues and coming back to the heart. That's why the venous sample contains very low oxygen level. Bicarbonate 22, 26, it is same in venous sample. Base excess same. Oxygen saturation more than 95% in arterial sampling, and it is 60 to 80 in venous sampling, because oxygen is utilized in the tissues and desaturated blood is sending back to the heart through the veins. Now once you make a ABG and once you get a report, from there clinical features are very important. Like you can see a lot of clinical features like breathlessness, wheeze, crepitations, X-ray may show consolidation, patient is having cardiac failure, echo may show reduced ejection fraction. So many clinical features we have to consider when we are interpreting an ABG. So some important conditions I'll just read out. Acute respiratory acidosis and chronic respiratory acidosis. In both these conditions you can see pH is reduced. Why pH is reduced means carbon dioxide is retained. That increases carbonic acid. So primary, in any patient who is having lung disease with breathlessness, in a primary lung disease, most of the time the primary problem is carbon dioxide retention. This happens in type 2 respiratory failure. Whereas in type 1 respiratory failure, only hypoxemia is there, carbon dioxide is not retained, so it will not produce any acidosis. So PaCO2 is increased, that's why pH is reduced. Compensation occurs after some time. Immediately compensation will never occur. Compensation occurs normally in chronic respiratory acidosis. You can calculate the compensation like 1 millimeter of mercury PaCO2 increase, 0.5 milliequivalents of bicarbonate increase, pH can reduce by 0.0025. So that is respiratory acidosis. Normally you get respiratory acidosis in severe COPD and prolonged asthma. Immediately once the patient is admitted with asthma, you may not see respiratory acidosis, but a prolonged asthma you get respiratory acidosis, whereas in COPD patient will have continuously high carbon dioxide. On exacerbations it can increase. ARDS, pneumothorax, respiratory muscle weakness, CNS depression with respiratory paralysis, all these things you can see respiratory acidosis. After sometimes it may try to compensate. Another important condition we deal in emergency room is metabolic acidosis. Here you can see the bicarbonate is reduced. You can see bicarbonate is reduced, pH is reduced because it is acidosis. To compensate that, you can see PCO2 also reduced. We already explained how it is reduced, because the brainstem will give signal to lungs that there is acidosis. So lungs will try to breathe fast. They will remove carbon dioxide, so that in metabolic acidosis with decreased bicarbonate, body will try to decrease PaCO2 also. So that will compensate for the acidosis. So reduction in 1 milliequivalents bicarbonate, you can see reduction of 1.25 millimeter of mercury PaCO2, and pH is reduced by 0.012. So mainly you get in diarrhea, proximal RTA, diabetic ketoacidosis, lactic acidosis, salicylic poisoning, renal failure. So many conditions you can get metabolic acidosis. Other conditions I am not explaining now. When we discuss about these type of conditions, we will go to that. Now you can see this chart. This will give you how to calculate or how to analyze an ABG. You can see the acidosis part. We will not be able to discuss everything now. pH 7.35 to 7.45 is normal pH. If it is less than 7.35, you can think it is acidosis. In acidosis, there are two important conditions. One is respiratory acidosis, other one is metabolic acidosis. Respiratory acidosis, you can see the pH is low. That is because carbon dioxide is retained, carbonic acid is high, so pH is reduced. To compensate that, you can see bicarbonate is elevated. Common conditions are COPD, pleural effusion, pneumothorax, CNS depression, drug-induced CNS depression, chest deformities. Whereas in metabolic acidosis, the primary defect is bicarbonate is reduced. To compensate that, carbon dioxide also reduced. This is by rapid breathing. Lung removes carbon dioxide. Here you can see pH is reduced, bicarbonate is reduced, carbon dioxide also reduced. In that again, high anion gap metabolic acidosis is there, low or normal anion gap metabolic acidosis is there. So when we discuss this type of acidosis, we can discuss all these things. Same like that on opposite side, if the pH is more than 7.44, it is alkalosis. Again, two important causes for alkalosis: respiratory alkalosis and metabolic alkalosis. Respiratory alkalosis commonly seen in hyperventilation syndrome. That both conditions pH is elevated, and respiratory alkalosis, the primary problem is carbon dioxide is washed out. To compensate that, chronically you can get bicarbonate also reduced. But most of the time respiratory alkalosis is a short term problem. Compensation very rarely we see in this type of problems. Metabolic alkalosis, again pH is increased, bicarbonate is increased, PaCO2 is increased. So that is metabolic alkalosis. Now metabolic acidosis we have seen in detail previously. Metabolic acidosis, what we are seeing is pH is reduced because of acidosis, bicarbonate is reduced because of metabolic acidosis. Initially it will not be compensated, so PaCO2 will be normal. But after some time, patient will try to breathe fast and removes carbon dioxide from the lungs, through the lungs, so PaCO2 also will be reduced. This compensation can be calculated from bicarbonate level itself. So arterial compensation can be calculated by 1.5 into bicarbonate plus 8 plus or minus 2. That will give the bicarbonate level from the carbon dioxide level from the bicarbonate. Metabolic alkalosis, you can see pH is elevated, bicarbonate is elevated. Initially PaCO2 will be normal, but afterwards you can see PaCO2 also will be increased by the patient will try to reduce the rate of breathing, so the carbon dioxide retention will occur and try to increase the pH. PaCO2 can be calculated from the bicarbonate level by 0.7 into bicarbonate plus 21, that will give the value. Respiratory acidosis compensation, again the body will try to compensate when the patient is having respiratory acidosis like COPD and all. Kidney will try to retain bicarbonate or hydrogen ion, so the body can retain alkalis when there is acidosis on the lung side. Respiratory alkalosis also can be you can see here acute respiratory acidosis, the compensation is reduction in the bicarbonate. For every minus 10 of carbon dioxide you can get reduction of bicarbonate by minus 2, whereas in chronic respiratory alkalosis minus 10 equals to bicarbonate minus 5. So we have discussed about very basics of acid-base balance. We didn't go into the depth of various type of acid-base disorders. We are just told how the body is maintaining pH in between 7.35 and 7.45. But when we are discussing acidosis, there are different types of acidosis: high anion gap acidosis, low anion gap acidosis, normal anion gap acidosis. Like difference is there. Again, we have to learn about compensation, what type of compensation occurs in chronic types of acid-base disorders. All these things we will learn once we are discussing the different types of acid-base disorders. Thank you.